is to me except Lord of all the worlds. He is the one who created me, and He alone guides me. He is the one who provides me with food and drink, and He alone heals me when I am sick. He is the one who will cause me to die and then bring me back to life. He is the one who I hope will forgive my flaws on Judgment Day. Sadaqallahu Azim. So the key message here is that healing belongs to Allah and medicine is our trust and responsibility. So starting with our case, we present you a 70-year-old male with ptosis and visual loss. This case has been in collaboration with radiology department, neurology, ENT, and infectious disease. So the outline is the recitation of Holy Quran, then the case presentation by me, input from radiology, neurology, ENT, and infectious department, and then literature review and learning points by Dr. Ashar, our senior registrar in medical unit. So starting with the case, the name has been anonymized Mr. XYZ. He is a 70-year-old male. He is resident of Rawalpindi, ex-businessman by profession. He is married and he presented in medical unit to outpatient department from where he was admitted in ward. He presented to us with a complaint of headache and left eye pain for past 10 days, drooping of eyelid on the left side for past 10 days, and visual loss in the left eye for past 3 days. Pre-orbits of the patient include diabetes mellitus type 2 since 2010. He is known case of COPD for past 2 years and ischemic heart disease since 2021. Moving further, when we inquired about the history of presenting illness, we found out that the headache was on the left temporal nature and left eye. It was sudden in onset, dull and throbbing in character. It was non-radiating, associated with left periorbital swelling, with no aggravating or relieving factors. He denied any diurnal variation or prior such episode. Buccal eyelid process was also found to be sudden in onset. It was located to left side only. It was complete in nature, associated with left side nasal stiffness and left facial numbness. There were no excessive tearing, redness of eye, or dryness. It did not relate to any rest, activity, or time of the day. Visual loss was found to be sudden in onset. It rapidly progressed to complete visual loss, also located to the left eye only. There was no history of curtain-like shadows, halos around the light, flashes, or flickers of light, or sputtering. There was no pain, jaw claudication, and scalp tenderness. We moved to the systemic inquiry. On general inquiry, there was no history of fever, weight loss, anorexia, and lung symptoms. There was no cough, dyspnea, chest congestion, or sputum, or hemoptysis. No history of orthopnea, nocturnal dyspnea, palpitations, or edema. No terminal pain or bowel complaint. No joint pain, rash, Raynaud phenomena, or toxicity. In CNS, he had no weakness, altered mutation, dysarthria fits, or loss of consciousness. There was no urinary or genital complaint. Systemic inquiry was insignificant of any particular symptom. Patient was smoker with 40 pack year history. He educated till matriculation. There was no history of any substance abuse. He lives in his own house with son and wife. In past medical history, he was treated for myocardial infarction in 2021 with PCI done to left anterior descending and left circumflex artery. Previously, he was admitted 2 times for exacerbation of COPD in past 6 months. He was stabilized in hospital and was discharged. He recorded multiple OPD visits for his uncontrolled diabetes. In treatment history, he had for ischemic heart disease, he was taking dual antiplatelet with a dose of aspirin 75 mg and clopidogrel 75 mg only. He was on statins 20 mg HS, ACE inhibitors, beta blockers, diuretics, and mineralocorticoid receptor antagonists. His last visit to cardiologist was recorded 8 months back. For COPD, he was on inhaled formoterol and budesonide along with inhaled ticagrelor. For diabetes, he had been taking metformin 850 mg and epagliflozin 10 mg only. Previous allergic history, there was no known drug allergies. Family history was found to be insignificant of any autoimmune or malignant disorder. He belonged to an upper middle class family with an average income of approximately 3.5 lakh per month. After the detailed history, we moved on to the clinical examination. So on general physical examination, we found that the patient was well oriented in time, person and place. He was comfortable during examination with no respiratory distress. There was no jaundice, pallor, clubbing, cyanosis, edema, or lymph nodes. Blood pressure was 120 by 80, saturation 97% at 2 a.m. Respiratory rate of 14 per minute, pulse 105 per minute, and temperature 98 per minute. So after the general physical examination, we moved to the local examination of the eye. We found that on inspection he had complete proptosis, and swelling over the left periorbital and maxillary region and xanthelasma of periorbital region. Here in this picture, you can demonstrate on the left side the patient having complete ptosis and proptosis and swelling over the periorbital region. In this picture, we lifted up the eyelid to have a clear vision of the people, which I hope you won't be seeing here, but they were found to be fixed eyelid, not responsive to light. We moved on to the cranial nerve examination on the left side. First, we did the optic nerve, cranial nerve 2. We found that patient had no perception of the light. The vision field could not be assessed due to visual loss. Color vision was found to be absent in the left eye. Pupillary reflex showed fixed dilated pupil with absent direct and indirect reflex. Fundoscopy revealed pale optic disc. Similar findings could not be found on the right side, and the right eye was found to be completely normal. After this, we move to cranial nerve 3, 4, and 6. So here I would like to ask anyone from the final year, what can you exactly depict in this picture?
This image basically depicts the extraocular examination, the movement of the extraocular examination of the eye. And in this image, we can see that when the patient is commanded to look forward and move his eyes, according to the command given, he can move his right eye in upward, downward, medial, and lateral respect. But the left eye is static, which shows that the extraocular movements are intact in the left. The extraocular movements are intact in the right eye, but there is complete ophthalmoplegia in the left eye. We can also see the ptosis in the left eye when the finger is released, and we can also observe there is mild dilation of the pupil in the right eye.
Thank you very much, very good. To simplify it for the rest of the people, I would say, first of all, look at the right eye. Here you can see the right eye is moving in every direction we command. Then look at the contralateral eye, seeing the right eye. During the movement of the right eye, the left eye is completely static and it is not moving at all, suggested that the left side was involved. Here you can see process in this patient, and on the first slide the eyelid has been lifted with the help of the finger. These were the exact movements that we depicted in the picture, and to simplify it for you, we added it in this form. These are the findings: the complete loss of eyebrow movements in the left eye. Eye movements of the right eye were completely normal. We noticed complete ophthalmoplegia on the left side. Moving further, we checked cranial nerve 5. On trigeminal nerve, we observed reduced sensation in forehead and periorbital region and over the left cheek and upper lip, which involved the B1 and B2 component of the trigeminal nerve. Sensation over the lower jaw and lower lip and chin was normal with normal jaw joint reflex, showing that the B3 component was intact. Rest of the cranial nerves that has not been mentioned here were intact. Moving to the examination of the nose, on inspection we noticed facial swelling and tenderness with periorbital edema. Nasal cavity examination showed crusting and foul smelling discharge. Congested edematous nasal mucosa. Swelling of left middle turbinate was found that represented sinusitis. The next part of our examination was systemic examination. In respiratory examination on inspection, we noticed barrel-shaped chest with reduced movements bilaterally. Trachea was found to be central and reduced chest wall expansion. Percussion note was bilateral resonant and auscultation revealed bilateral expiratory release. These findings are consistent with the diagnosis of uncontrolled COPD that we have. On serious examination, we noticed that he was not having any visible scar, deformity, or pulsation. Apex beat was localized in the left fifth intercostal space in the mid-clavicular nerve. There was normal first and second heart sound, which showed he did not have any signs of associated pulmonary hypertension. Abdomen was flat with inverted umbilicus, with no scar or pulsation. There was no orthogonal or mass, with no shifting dullness or flow effect. Vowel sounds were also audible. So upon moving to the motor examination, one of the most important component in our case, we found that the motor examination of the upper and lower limb, he had bilateral equal bulk with no wasting in both of the upper and lower limb. With normal tone, power 5 by 5 in all groups of muscle. Coordination was found to be intact. He had reflexes of grade +2 in upper limb and grade +1 in lower limb. We moved on to the sensory examination. We found that in both upper and lower limb, light touch, pain, and temperature was intact. However, proprioception and vibration was found to be impaired distally, revealing that he had some sort of sensory neuropathy. So what would be the differential diagnosis on the basis of history and clinical examination? If anyone from the final year can please tell me. Anyone from this side, better? Anyone? Okay, no one? Anyone from this side?
आपको क्या लगता है पेशेंट है डायबिटीज है उसको अनकंट्रोल्ड है और उसको नोज में से बहुत स्मेल आ रही है ब्लैक फिश अंदर मटीरियल है नोज में ध्यान में आता है कोई चीज फंगल इन्फेक्शन स्टोरी बोलिए तो सोचेंगे ना अच्छा समझ आ गया तो फंगल इन्फेक्शन हो सकती है ठीक है ना जी प्लीज
Okay, good. So, make it simpler for you. The differential diagnosis we had in mind after which we took forward the case include orbital cellulitis, orbital apex syndrome, cavernous sinus thrombosis, superior orbital fissure syndrome, diabetic ophthalmoplegia, and Lewis-Hamilton syndrome. So after this, for the neuroanatomical localization, I will invite Dr. Pratim Rashid, who is currently heading the neurology department in HFH, to further guide us. Bismillahirrahmanirrahim. Assalamu alaikum.
First of all, I will discuss the differential diagnosis. We overview then the anatomical localization and the effect caused by lesions in these structures. The differential diagnoses are, first of all, I will start with preorbital facial syndrome, then secondly orbital epic syndrome, then the cavernous sinus thrombosis, then orbital cellulitis, diabetic ophthalmoplegia, and Solowa syndrome. The superior orbital fissure, orbital apex, and cavernous sinus. These three can be inflammatory or can be infective in origin family images. Orbital cellulitis are always infective. Diabetic ophthalmoplegia is vascular in origin, and Tologa can be infective or inflammatory. These are orbital apex, preorbital fissure, and cavernous sinus can occur as an independent entity or there can be an overlap between these three. And to another hand can be localized either to orbital apex or to superorbital or to cavernous sinus. What is the brief anatomy of the superorbital fissure and the orbital apex? Superorbital fissure is the fissure between the greater and the lesser wing of the sphenoid bone. Here you can well observe that there are the mainly in in superorbital, orbital apex, and cavernous sinus. There are some common things and some differentiating points. First of all, the superorbital fissure. Third nerve, both the superior deviant and the inferior deviant of the third nerve pass through the superorbital fissure. Then the fourth nerve, third nerve is the oculomotor, fourth one is the trochlear. And the fifth nerve, first deviant of the fifth nerve, which is further subdivided into lacrimal, frontal, and the nasal ciliary branch. Lacrimal, frontal, nasal ciliary of the fifth, V1 ophthalmic deviant, the fourth nerve, and the third nerve, and the adjacent nerve. So you can see from a suborbital fissure, the third nerve, the fourth nerve, the V1 and the sixth. These four nerves pass through the suborbital fissure along with the superophthalmic vein. When you combine the suborbital fissure with the optic canal which contains the ophthalmic artery and optic nerve, the combined entity is orbital apex. So suborbital fissure containing third nerve, fourth nerve, first deviation of the fifth nerve and the sixth nerve. When these combined with the optic canal, it forms the orbital apex. So if any lesion infective or inflammatory is localized to suborbital, then it is called suborbital fissure syndrome. If it involves the optic canal, which is optic nerve and the ophthalmic artery, then it forms the orbital apex syndrome. Now there is brief anatomy of the cavernous sinus. The body of the cavernous sinus has a cavernous segment of the internal carotid artery along with the sixth nerve. And the lateral wall contains the third nerve, oculomotor, the trochlear, and the V1 and the V2 deviant of the fifth trigeminal nerve. The same picture, the internal carotid cavernous segment. Here is the adjacent nerve, oculomotor, trochlear, V1 and the V2. In this is the tabular form of the differential. Superior orbital, the basic one, cranial nerve third, cranial nerve 4, and the cranial nerve 6 and the V1. Third, 4, V1 and the 6 in the superior orbital fissure. If you add optic nerve with third, 4, V1 and the 6, it forms the orbital apex syndrome. And in the cavernous sinus, the third nerve, the fourth nerve, the sixth nerve, here you add the V2 branch, the maxillary branch of trigeminal nerve along with sympathetic fiber. So to learn, superior orbital fissure contains third, fourth, V1 and the sixth. Orbital apex contains third, fourth, V1, sixth along with the optic nerve. And the cavernous sinus contains third, fourth, V1, V2, sixth along with the sympathetic fiber. Now in this patient, there was loss of VN along with complete ophthalmoplegia. Complete ophthalmoplegia means external and internal ophthalmoplegia. External ophthalmoplegia means the patient is unable to move his eyes in any direction. Mentioned in this picture, the right eye is moving upward and outward, lateral gaze, downward and outward, downward and the inward, but the left eye is fixed in the center position. It means it's the external ophthalmoplegia. Internal ophthalmoplegia means the patient's pupil is dilated and non-active. So this patient has complete left ophthalmoplegia. So in the differential diagnosis, here is the third, fourth, V1 and 6, but there is no involvement of the second nerve. In orbital apex syndrome, there is superadded involvement of the second nerve. So likely this patient has involvement beyond the superior orbital fissure, likely at the orbital apex, or it can be cavernous sinus thrombosis. There are pressure effects that lead to the involvement of the second nerve. If a patient has second nerve, there will complete vision loss, likely like in this patient RAPD, there is no RAPD because the pupil was fit dilated. If third nerve is involved, there will ptosis and dilated non-active pupil, and the patient will be unable to elevate or depress or mainly move the third eye. If cranial fourth trochlear nerve is involved, there will be lack of downward and inward movement of the eye. If abducens nerve is involved, patient will be unable to move the eye to lateral gaze. And if the V1 is involved, there will be loss of sensation in the forehead and the cornea. But this patient has extended involvement up till V2. So likely this patient has a lesion which is localizing orbital apex and also extended to the cavernous sinus.
Thank you so much, sir. So moving forward, we investigated the case with targeted investigations. We found that he had hemoglobin of 14.6 gram per deciliter, raised TLC count of 14,000 millimeter cube. Platelets were found to be 3 lakh and 83,000. MCV was 88 femtoliter with MCH of 30 picogram. Hematocrit was 42%, neutrophil count 70%. He had raised inflammatory markers. ESR was found to be 45 and CRP 24. Then we sent the biochemistry, metabolic panel, and cultures of the patient. We found that he had uncontrolled diabetes with HbA1c 14%. Urea creatinine was found to be normal. Serum electrolytes revealed sodium of 135, potassium 4.5, and chloride 105. Serum calcium levels were 8.9. He had normal PCO2 in ABGs, which showed that he was not in type 2 respiratory failure. He had normal LFTs, lipid profile revealed cholesterol of 180 and triglyceride 130. Cultures revealed no growth after 48 hours. So after these investigations, we performed radiological scans of the patient, and to demonstrate that, I would like to invite Dr. Pinish Nadeem, Assistant Professor in Radiology, to guide us further.
Bismillahirrahmanirrahim and Assalamu alaikum. Okay, so far we are, kind of an idea that the disease, whatever the pathology is related to the left orbit, and somewhere in the nose and sinuses must be involved, and because there is a marked swelling in the clinical examination. But before starting the discussion of the case, I will first like you to see a little brief anatomy, radiological anatomy, that is very important in this case. So here we can see this is a coronal CT image for your understanding. Uh, the important radiological landmarks that are to be seen in the CT. Number one is cribriform plate. Anything, either cancer or aggressive infection, inflammation, going from the nose or the sinuses towards the brain, extending into the brain, into the frontal lobes, should reach this small linear cribriform plate. So if we see any defect in the cribriform plate, we know that the thing has gone into the brain, right? And if anything from the nose or the sinuses are going in the orbit, we will see the breach in the medial wall of the orbit, that is lamina patricia. So integrity of cribriform plate and lamina patricia is very important when we are looking for any sinonasal disease pathology. So this is the actual CT coronal images of our patient. We can see the blue arrows. What are they actually telling us? We can see some hyperdense heterogeneous areas involving the, please finally you have to see it, otherwise you are not going to follow that. Heterogeneous areas in the left inferior nasal fasciculate, left nasal cavity, left maxillary sinus, causing the widening of left osteometrial complex, and then the disease pathology is somewhere extending cranially to the frontal sinus. There is no breach in the cribriform plate. It means that fortunately the thing is not going upward. But unfortunately, we can see a breach in lamina patricia here. So these heterogeneous areas are basically extending from the nose to the sinuses. Sorry, I think I just missed it. Sorry. From the nose to the sinuses towards the orbit, with a breach in the lamina patricia. Here you can also see that the medial rectus, inferior rectus, superior rectus, and the optic nerve is also inflamed. We can see the stranding over there, along with some increase in the sinuses. So let's move forward. This is the MRI of the same patient. Coronal views and axial views, situated images, and even post-contrast I put forward for you. Here again, as seen in the CT, we can see hyperintense. Here we say intensity instead of density in MRI. Hyperintense areas, left maxillary sinus, left nose, left nasal orbits, terminates going through the osteometric complex and then extending into the left orbit. Here we can see some very, unique thing. What is this black hypointense lines, the strands seen in bilateral maxillary sinuses and going towards the orbit? In radiological point of view, these are fungal hyphae. And fungal hyphae are always hypointense on MRI despite of any sequence. Why? Because fungal releases manganese and iron component. These are the paramagnetic ions. These have some, some complex things going on in MRI, which makes them very hypointense. So whenever we see some thread-like structures going from the sinuses towards anywhere, we know that this is superimposed fungal infection along with the aggressive sinusitis. So here we can see some fungal hyphae going into the orbit. This is the axial view to give a good anatomy of the orbital apex, and we can see that there is some stranding, some fat stranding. We can see from the contralateral side. There is some fat stranding, and the orbital apex, this is the apex, is somewhat narrowed. So this is the last image for your attention, please. This is the first image. I've taken it from the net. Finally, here, please. I need your attention. This is the first image. I've taken it from the net with almost similar pathology, but on the right side. Here I can see that there is some inflammation in the right maxillary sinus going into the nose, but there's some difference from our case that the turbinates are not enhancing, they are black, that they are hypo-intense. What does that mean? It means that the disease process has already compromised the vascularity of the turbinate and now they are ischemic and necrosed. So, my question is that this is our case. What about the turbinates here? Is the black turbinate sign positive here or not? No, it's not. Fortunately, the turbinates are still showing the enhancement and it means that the turbinates are vital. So, based upon the imaging, we made a provisional diagnosis of invasive fungal sinusitis with extension intraorbitally on the left side. This is all from radiology. Thank you so much.
Thank you so much, madam. So, after the radiological scans, we go for the microbiology, and we found that the nasal swab were positive of the fungal hyphae grown on Saccharot agar, and it was grown to be mucus species. So, I would ask finally again, what is the diagnosis now? Good, excellent. So, the final diagnosis that we established was orbital apic syndrome secondary to mucormycosis on the background of COPD, complicated diabetes mellitus, and ischemic heart disease. So moving to the management. So when we admitted the patient, the initial treatment after the detailed history and examination, we first suspected orbital cellulitis and we started the patient on vancomycin for staph coverage and carbapenems for gram-negative coverage. We started the patient on IV fluids. We gave paracetamol for the pain, thromboprophylaxis. The cardiac and the COPD medications that I showed you before were continued, and glycemia control was achieved with basal bolus regime. So after the CT and MRI and fungal cultures, we started the patient on injection amphotericin conventional at the dose of 1 mg per kg 24 hours with standard protocol. The standard protocol is diphenhydramine or promethazine 30 minutes before infusion. 500 ml IV normal saline bolus was given to reduce nephrotoxicity. Before that, 1 mg amphotericin was given as a test dose to avoid hypersensitivity. And during this treatment, we monitored electrolytes and creatinine every 24 hours. After CT and MRI, we involved ENT department for surgical debridement and test for the removal of necrotic debris and infected tissue. And for this, I would like to invite the head of department in ENT, Dr. Ashar, to guide us further in this course.
Assalamualaikum. So I am representing Department of ENT Holy Family Hospital, Rawalpindi, Pakistan. And as you know, this is a very interesting case of complicated diabetes and with the involvement of the nose, sinuses, and orbit. So we have a diagnosis of mucormycosis, a very dangerous condition and very expensive condition. It readily involves the adjacent structures. So the role of ENT in the management is very crucial. So what we do is basically, before discussing this, I would like to tell you about different types of fungal rhinosinusitis. There are two types, non-invasive and invasive. The non-invasive is simple fungal wall or aspergilloma in the maxillary sinus or sphenoid sinus. Next is allergic fungal rhinosinusitis. The patients who present with allergic symptoms. Then in invasive, we have chronic granulomatous invasive fungal sinusitis. Then we have chronic invasive fungal sinusitis. And what we are discussing now, it is acute necrotizing invasive fungal sinusitis. And this is the most difficult and most, you can say, highest mortality rate this disease has. So, how these fungi spread? They spread through the blood vessels which is called angioinvasion. Then they lead to thrombosis of the vessels, which leads to tissue necrosis. And as you can see in this slide, what are the signs? The patient presents with nasal obstruction, epistaxis, facial pain, false swell from the nose. If the disease involves the orbit, there will be proptosis, chemosis, and thermoplagia. And there, on examination of the nose, we will see black necrotic scars in the nose, in the nasal cavity, in the turbinates, as well as you can see there is blackening of the hard palate. This is also hallmark of mucormycosis. So there will be erosion of the nasal septum and the hard palate. So which sinuses are mostly involved? 86% of the ethmoid sinuses are involved, and in most of the cases. Then on second number is the maxillary sinus, which is 79%. On third number is sphenoid sinus, which is involved in 60% of cases. And the least involved is the frontal sinus, which is 2%. So what we do? Our aim is to limit the spread of the infection from nose further to the into systemic into the other parts of the body. So what we do, we remove the excessive tissues. First of all, we take tissue for biopsy and for fungal cultures. Although it is a clinical diagnosis, but still we need some evidence for gold standard evidence for the final diagnosis. And after that, we do extensive debridement. We resect the infected area, necrotic areas from the nasal cavities and the sinuses. And if the disease is going into the orbits, we clear it from the orbits to limit the spread of the infection and to decrease the fungal load. So, as you can see in this video, the turbinates were spared as you have seen in the MRI. And this is the blackish scar tissue you can see in the left maxillary sinus, which is being cleared. We are working in the middle meatus. As you see, the most of the sinuses they open into the middle meatus, maxillary sinus, ethmoid sinuses. So we are clearing the disease from the middle meatus, from maxillary sinus as well as ethmoid sinuses. You see the blackish color of the tissue, it is necrosed. So this, sir, it is a necrotic tissue, basically dead tissue, sir. The vessels have been necrosed due to fungus, and the tissue is dead now, and it is loaded with fungus. So we have to remove the glucosa and the dead tissue, otherwise this will lead to further expansion of the necrosis and expansion of the fungus. Yes, mucormycosis, sir, this one. So, इसके अलावा सर कैंडाइट okay. So thank you very much. This is all from the ENT side. Yes, sir. But in this case, it is mucosa.
Thank you so much, sir. So this is the total course of the patient. On day 0, he was admitted by OPD. Till third day, he had full clinical workup, CT scans, and he was started on antibiotics. IV, which I just showed you, as we had the suspicion of orbital cellulitis at first. From day 3 and 5, we had MRI done traced, and he was started on injection amphotericin. From day 7 and 9, we involved multidisciplinary team. Day 10 and 12 with the involvement of FES and surgical debridement from the ENT department. On day 13, we overlapped with isoconazole as the patient was unwilling for further injection amphotericin. As we started on a new drug, from day 14 and 21, we had a key watch on electrolytes and RMTs. On day 22nd, he was stabilized and discharged on isoconazole with follow-up in OPD. So this was from my side. Now I would like to invite Dr. Leza for the literature review of mucormycosis. Thank you very much.
Assalamualaikum. I'm Dr. Neza, and I'm here to review the literature related to mucormycosis. So first of all, we are going to discuss the mycological features of mucor. The most common bug is the mucorales. It is very commonly present all around us, but it usually do not infect us. The infection takes place when the immunity is compromised. So anything that compromises the immunity exposes us to the bug and results in infection. The most common of the organism is the mucorales that is responsible, and the most common species is Rhizopus. This is a film that is showing the characteristic features. The mucorale is non-separate organism having the right angle branches as shown by the arrow here. The table is showing the difference between the mucorale and the Aspergillus, as the other common bug that is present in the nasals and the sinusitis is Aspergillus, so the histopathological features of two are different for diagnosis. The pathogenomic mechanism involves the three stages. First of all, involves the invasion of the bug, in which the inhalation is involved. In the second step, the immunity of the host is compromised. There are multiple factors that can result in the decreased immunity, like diabetes, like the use of the steroids, or some other disease like HIV, or any other, like decay impairs the macrophages, or any other disease leading to the decreased immunity and defective natural killing cells and the responses. And the third step of the pathogenesis is angioinvasion, where the bug invades the vessels, then result in thrombosis and necrosis of the tissue. This is the pictorial representation of the previous slide, in which first after the inhalation, they bind with the receptors in the epithelium of the nose and then the epithelium of the pulmonary musculature. Then they invade the vessel, where they result in thrombosis and then inflammation and necrosis of the tissues by the release of the toxins that are the mucorrhizins. These are the risk factors for the development of the mucormycosis. Diabetes is a very important and commonest of all the risk factors that result in decreased immunity. Increase in the glucose in the blood enhances the proliferation of the bug, specifically decay, as combination of the hyperglycemia and acidic environment allows the bug to proliferate very rapidly. Hematological cancers, leukemias, lymphomas, and the hematopoietic stem cell recipient having the graft versus host disease are also responsible. Are the important risk factors. Transplant, including the solid organ transplantations. Glucocorticoid use, trauma, and the burn is a risk factor. And the use of the despiroxamine, iron, overload, AIDS, drug use, and malnutrition. In Pakistan, 14 out of 1 lakh cases annually has been reported. This is the data that has been taken from a tertiary care hospital in Pakistan in the era of the COVID. COVID is one of the most important times which resulted in decreased immunity. And in the times of the COVID, the 43 cases has been reported in a tertiary care hospital, in which 22 were COVID and 21 were non-COVID. All of them were receiving steroids and 88% of them were diabetic. So again, decrease in immunity is one of the most important risk factors in allowing the proliferation of the bug in the individuals. These are the clinical manifestations and the types on the basis of the clinical manifestation of mucormycosis. The clinical form has been divided on the signs and the symptoms as sino-orbital, in which the patient will present with nasal Ashar, peri-orbital edema, and palatal necrosis. The mortality in these cases will be 25 to 60%. The next clinical form is rhinocerebral, in which the patient will present with diplopia, focal defects, and carotid involvement. Mortality is high in such cases, is about 60 to 80%. Then sinopulmonary, in which the CT scan of the patient will be showing reversed halo sign. Patient will be having respiratory symptoms like hemoptysis and fever. Mortality in such cases will be 60 to 90%. Cutaneous or mucoskeletal type of the mucormycosis usually occur after the traumas, burn, combat injuries, and the fight. The patient will develop the skin Ashars in these cases and the deep tissue necrosis. Mortality in such cases are variable. Gastrointestinal type of the mucormycosis usually present with abdominal pain and hematosis. This is the pictorial presentation. The picture C is showing the reverse halo sign, in which there is the central hypodense area surrounded by the denser layer. This is the presentation in which the patient after inhalation develop acute sinusitis, then palatal Ashars, and then the cranial nerve involvement. These are the emergency early warning signs of mucormycosis, which lead to the early detection is very important in these patients. So identification of these signs are important. The culture and histopathology are the main pillars in diagnosing the disease. These are the microscopic features of in the two different types of the strains, immune fluorescent strains and the PAR strains, and both are showing right angular branching of the mucor patient. This is the diagnostic approach. First of all, you should maintain a high clinical suspicion, then the urgent imaging should be performed, then you should take the tissue biopsy, and then microbiological confirmation. These are 5 pillars. First of all, detect the mucor, then start antifungal therapy, then you should perform the surgery for debridement and get the sample, then build the immunity of the patient and correct the metabolic environment. Antifungal therapies are latrozomal and conventional amphotericins. Posaconazole and isavuconazole are the maintenance therapy. We usually overlap when we shift the patient to maintenance therapy. This is the treatment algorithm, in which first we start liposomal amphotericin B and then we switch to posaconazole and isavuconazole. And the duration of the therapy is dependent upon the resolution of clinical and radiological symptoms. In most of the cases, it is a long-term therapy, and in immune compromised stage, it may lead to long-term, even lifelong therapies may be needed. Now, surgical debridement is important to reduce the risk and attempt measures to reverse the immunity and correct the resources. These are the mortalities and the outcome and prognosis of the patient. In the future direction, we have the newer agents, including the oral nanoparticles of amphotericins that we can use for treatment of mucormycosis. Now, I would like to invite Dr. Mujib to further elaborate.
Dr. Mohammad Mujib Khan, Assistant Professor in HOD Infectious Diseases for brief comments.
Bismillahirrahmanirrahim, much has been elaborated in detail. I'll just emphasize on one thing. Always remember 3 Ds for management of mucormycosis. First D stands for detect early as possible, otherwise you'll lose your patient. Second number, pick drug as early as possible, as already has been elaborated that amphotericin is required and subsequent management. And the third one is debridement as early as possible. These are considered as 3 pillars of management of mucormycosis. If you delay diagnosis of mucormycosis for more than 5 to 6 days, mortality increases twice as compared to on day first. It may range up to 80 to 90% if untreated. I think much time has gone. Thank you very much.
Thank you very much. If there are questions, they are welcome. Otherwise, we are going to have comments from the Vice Chancellor.
Question, please. I believe people sitting at the back, they have the right to see these slides also. We should make them visible. It is easy. Half of the screen is not being utilized. So that backbenchers can they have the right to listen. This is the ethics of this CPC.
Thank you, sir. We will improve this. So, thank you very much, Professor Puram and team. And I have the same observation what Professor has pointed out. What to take care of the time. Because the time is 9:50, this being 9:50, there's so many people has to go. And secondly, the quality of slide and presentation. So I have the same concern as Professor has. Thank you very much. The next point is the CPC terms. So I think it is getting thinner and thinner, and the principal staff's request to be to stop people from appearing from modules if their attendance is less than 85%. So because this is otherwise no time having CPC, अगर लोग तालियां बजाने के लिए तो ठीक है, लेकिन आने के लिए पीछे आधार उठा लिए, तो ये एक जो है notification निकाल दें. So if people don't want to listen, they don't want to listen. We are not here to force anybody, but we follow the rules. So I think the best part was END. Let me appreciate. Wonderful and very precise, and I really interested to have this video be published in the video journal. So thank you very much. And the next time we have one or two questions from the students also, because I agree it not only very CPC related, but one or two questions. Thank you very much.